लेट मी जस्ट सो जो आपकी इंट्रोडक्शन स्लाइड है वो आपके पास इसमें है या मैं अब दिखाऊं उसको?
ओ, इसमें तो मैंने नहीं डाला।
तो मैं डाल दे
लेकिन
मैं
आप ऐसा करिए ना, कुछ नहीं, मेरे नाम के नीचे जो लिखा है वही पढ़ दीजिए, चेहरा तो मेरा आ ही रहा
अच्छा।
है।
मेरे पास स्लाइड है वो, पर वही शेयर करके फिर वो टाइम
सब
वेस्ट होगा हमारा।
यही 5 लाइन लिखा है मैंने उसमें।
हाँ, मैंने
यही
देखा है
पांच
उसमें
लाइन
यही
पढ़
है।
दीजिएगा। बल्कि
तो
2 लाइन पढ़ने के बाद मैं कह दूंगा कि रुक जाइए।
ठीक है सर, whenever we are ready to go.
हाँ, आई एम रेडी।
We'll wait for 5 minutes so that some people can join.
ओके, यस यस, दैट इज वेरी इंपॉर्टेंट।
I've put in a message. Shweta has joined in.
ऐसे ही धीरे धीरे लोग आएंगे।
Sir, आएंगे.
हाँ, एक्चुअली अभी क्लिनिक टाइम भी है ना।
तो 8:30 बजे क्लिनिक टाइम.
करने वाले लोग 10 बजे तक बैठते हैं।
I think
Okay.
9:35 will start.
ये
8:35.
8:30,
Sorry, 8:35 will start.
राइट,
Yes.
डेफिनेटली, श्योर।
So make it full screen.
नहीं नहीं, समथिंग रॉन्ग हैज हैपेंड।
This is a MacBook, sir.
यस।
Ah, it seems like.
कहीं पे कुछ टच किया गड़बड़। नाउ इट इज ओके। बत्ती जला।
I think, sir, you can start.
ओके।
So,
Over to you, Anish, sir.
right, thank you. So, good evening, everybody, and it's glad to have you all here for the SORCON meeting. Today, we have an eminent speaker with us, Dr. Ss Jha. He is the director of Harichandra Orthopedic Research Institute, Patna, patron in chief of and founder president of Indian Orthopedic Rheumatology Association, advisor and expert in IOA guidelines on osteoporosis, President and Patron, Geriatric Orthopedics Society, and President, Indian Association of Age Management, Founder, President, Indian Orthopedic Neurology Association, and past President, Indian Foot and Ankle Society. The list goes on and it doesn't end. And
Right.
all are very much aware of his
Thank you. Thank you,
Dr.
Dr.
Ss Jha.
Anis. You can stop here and can I begin?
Just a second. So the topic for today, let me introduce that. That is obviously osteoarthritis through intra-articular interventions. And again, it's a topic which is close to many of our hearts. And Dr. Jha will take us through this journey in the next 30 minutes. I'll request everybody to keep the mics off so that the deliberation can go smoothly. Thank you so much, and over to you, sir.
Thank you, Dr. Anis. Well, friends, we are committed to the cause of osteoarthritis and osteoarthritis of the knee. So, can we really accelerate osteoarthritis through intra-articular interventions? Management of osteoarthritis of the knee has been very close to the heart of this association, and from time immemorial, we have started thinking how we can best treat them. But whatever treatment has been available for osteoarthritis of the knee, they have not been effective in either slowing the disease or arresting the disease. What happens in the beginning? When a patient comes, the cases are indolent in nature, not very severe symptoms, but they become clinically relevant later when non-immune and immune-mediated inflammatory events begin to dominate. So, what is the finality for a grade 4 or grade 5 osteoarthritis? It will have to culminate into joint replacement. And joint replacement is the fastest growing in number in developed countries. So, if we can defer a joint replacement, that is what we talk about this evening. So, emerging new targeted therapy, joint replacement can be deferred if the joint damage gets decelerated. Now, what happens? That degree of joint space narrowing is a very good study protocol and is positively associated with subsequent total knee joint replacement within 15 years. So, what is that mathematics? If we can calculate 1% rate of tibial cartilage loss, mind you, this is not femoral cartilage. So there will be 20% increased risk of undergoing total joint replacement within 4 years. So 1% becomes so very important, and this 1% is over a period of 2 years. But question arises, how do we really decipher the ultrastructure of the cartilage? It is, all of us are aware, MR cartogram is the investigation which is very sensitive to early cartilage damage, and it is a potential early marker for this earlier so-called degenerative joint disease, and it assesses articular cartilage integrity. Well, conventionally speaking, osteoarthritis is a synovial joint failure, and the pathodynamics, especially of one phenotype in which the subchondral bone is the seat of changes taking place. So initially what happens? Articular cartilage surface fibrillation takes place, osteophyte formation followed by subchondral bone sclerosis. There is chronic inflammatory response, and this drives the human OA finally into we can say synovial joint failure. We can almost compare it to a cardiac failure. Well, the very important point is that osteoarthritis has been changing its pathogenesis, and it was late 90s that switch to inflammatory theory came. So in 1990s, there was progress in molecular biology and discovery of inflammatory theory took place, which many soluble mediators such as cytokine, prostaglandins can increase the production of MMPs by chondrocytes. These were further confirmed by further imaging studies by Wallace in 2017, who demonstrated localized inflammation contributing to osteoarthritis. So friends, the inherent synovitis is the critical feature and driver of osteoarthritis process. So the inflammatory theory finally came into being in 1990 but was not accepted till 2000. And the inflammatory theory further kept on changing into finally immunometabolic disease. I will not go into details, but finally we say that osteoarthritis is a immunometabolic disease. So, a disease which initially was thought to be wear and tear disorder, there has been a paradigm shift in osteoarthritis from being viewed as a simple wear and tear disorder to whole joint disease driven by chronic low-grade inflammation, immune dysregulation, and metabolic dysfunction. Friends, crosstalk is always there between cartilage, synovium, subchondral bone, muscle, and adipose tissue, and they all lead to metabolic dysfunction. So, the seat anchor of the phenotype in which the subchondral bone is affected, what the subchondral bone does, it works as a mechanical damper. It is a source of inflammatory mediators implicated in osteoarthritis process in degradation of deep layer of articular cartilage. And this was initially considered cartilage driven, but this is much more complex disease. So the inflammatory mediators are released by not only the cartilage, but also bone and synovium. So what should be the desirable management short of joint replacement? The therapies which are coming, if they can forestall or decelerate progression of osteoarthritis to synovial joint failure. So we come to the topic how intra-articular management through the non-surgical procedure can help it. When we come to it, we have to look into what we had been using in 80s. So to prolong the action of glucocorticoids, we have observed that there is declining analgesic effect of regular intra-articular glucocorticoid within only 2 to 4 weeks. So FDA approved a drug to be used intra-articularly. This is now available not in India but abroad as Gilureta. This is extended release formulation of synthetic triamcinolone acetonide in PLGA at microsphere, which is a new drug delivery system. This provides prolonged intra-articular release, 32 milligram in single 5 ml dose is administered intra-articularly. This maintains concentration in joint for several months after a single injection, claims to provide greater pain relief for 5 to 10 weeks and maybe even up to 12 to 16 weeks. In India, we have triamcinolone hexacetonide, and this is 20 milligram per ml suspension. 1 milligram per kg for large joint is the dose, whereas 0.5 milligram per kg is the dose for smaller joints. Well, Gilreta has lower systemic corticosteroid exposure and hence is attractive for patients with diabetes because post-injection hyperglycemia appears to be less pronounced than with conventional crystalline triamcinolone. So friends, here is one drug, even in diabetic patient, this can be used. The second comes the small molecule inhibitor of WNT signaling pathway, which is wingless-related integration site. This drug, known as loresivivint, had a phase 3 trial, and in fact, it was found that actual disease-modifying osteoarthritic drug, it fits into that definition. 11th November 2022, efficacy data from phase 3 in osteoarthritis was released by Samumed company, and there was seen to be cartilage regeneration, protection from cartilage catabolism, and there was significant difference in joint space width. And that is what DMOAD drug should do. There should be a significant difference in joint space width with cartilage regeneration. So what is the current global status? Unfortunately, in spite of being successful, the Biosplice Therapeutic has submitted a new drug application. However, the drug has still not received FDA approval. Though this is a first-in-class intra-articular molecule inhibitor of CLK-DYRK kinases, which modulates the WNT signaling and inflammatory pathways. It is intended as a potential disease-modifying therapy for knee osteoarthritis rather than simply an analgesic. So, unfortunately, for some regions and most probably regions of cardiac events in these patients, this drug has still not been given FDA approval. Intra-articular small molecule VNTA. This also is effective in osteoarthritis knee, and it promotes cartilage extracellular matrix generation, thereby inhibiting osteoarthritis development. Well, this VNTA, unlike corticosteroids and hyaluronic acid, is being explored as a true disease-modifying osteoarthritis drug. But unfortunately, it has only shown disease modification in animal models. Now, this is available, the stem cell intra-articular, and there are two pharma companies which markets them, Stem 1 in the name of Stem 1 and Cyplostem. They are adult human bone marrow derived cultured pooled allogenic mesenchymal stromal cells, and mind you, this is on a vehicle of hyaluronic acid, and they are to be used in stage 2 and early stage 3. But in cases where either the patient does not want to get operated or there are regions because of which surgery cannot be contemplated, this can be used. The storage is -185 to -190 6 degree in vapor phase liquid nitrogen. So the drug has to be brought by flight to the center, and then only it can be done. A similar drug known by the name of risenasib is also used in critical limb ischemia. Because of the cost constraints, this has not been very extensively used, but patients who have had this are happier, and there the joint replacement can be deferred by few years. Another development is intra-articular gene therapy. So 2017, US FDA approved it. The name of the gene therapy is Invosa. This has originally been a South Korean product, and this is the first arthritis gene therapy. In vivo gene delivery by direct intra-articular injection, it expedites treatment, transduces synovial lining cells as well as chondrocytes through thickness of articular cartilage. It utilizes adenovirus vector. Well, this is the diagrammatic representation how this gene therapy utilizes the adenovirus vector. Next is sprifermin, and this is a recombinant fibroblast growth factor. This intra-articular study was very popularized by a forward trial, and it increases cartilage thickness, substantially reduces cartilage loss, and the structure benefits are seen at year 2 and is sustained at year 5. Dose is once weekly 30 mg, 3 doses, or 100 mg every 6 months or every 12 months. Now, friends, some of the drugs that I have enumerated had an untimely desanction, we can say, because they have not been approved. Similar is the fate of some of the drugs which are still in pipeline. So, number 1, pipeline drugs are Botox. It is known as BONTA. This is an investigational drug. It provides pain relief, but again is not recommended by FDA. The other one is capsaicin, again an investigational drug used for moderate to severe OA knee patients, not approved by FDA, but phase 3 trial has been completed. Number 3 is low molecular weight human serum albumin by the name Ampion. It was once considered one of the most promising biologic therapies for knee osteoarthritis. However, the clinical development has effectively been stalled. Again, another drug, tanezumab. This involves nerve growth factor, and this is a monoclonal antibody used in osteoarthritis, but no longer it is in clinical development for osteoarthritis, although it demonstrated the strongest analgesic effect ever reported in phase 3 OA trials. Its development was terminated in 2021 because the regulators concluded that the rapidly progressive osteoarthritis and joint destruction overweight its clinical benefits. This status has remained unchanged through 2026. I will not go to this one becomes important. There is some overlap between the pathogenesis of osteoarthritis and rheumatoid arthritis. So, the biologics or the DMARD drugs which have been used for rheumatoid arthritis were given a fair trial, but it was found that they are not effective in osteoarthritis of the knee, but it is effective in erosive hand osteoarthritis. And they are adalimumab, etanercept, infliximab, and even hydroxychloroquine and anakinra also. Well, there has been some development not only in the intra-articular various drugs that have been given, the local anesthetic, because whenever we give an intra-articular injection, we use local anesthetic. So intra-articular bupica vein could be potentially chondrotoxic, and there is already awareness regarding the use of lidocaine toxicity over cartilage. So new intra-articular local anesthetic also has evolved by the name Prelokin. There is a rapid onset of action and is stable, gets released quickly from the composition, and this can be used with hyaluronic acid. Friends, I just wanted to highlight that osteoporosis could be a common denominator and must be tackled appropriately. Well, zoledronic acid, risodronate, and there was an upcoming drug which was a oral one, that was disodium zoledronate. So intravenous zoledronic acid remains an investigational therapy for knee osteoarthritis, although early studies show encouraging reductions in patients with subchondral bone marrow lesions. Larger randomized trials have not demonstrated consistent structural or long-term clinical benefit, and the drug has not been approved for OA by any major regulatory authority. But in spite of this, zoledronic acid IV is effective in osteoarthritis patients. The oral drug that I have been talking about, disodium zoledronate tetrahydrate, has been withdrawn. Well, I will like to conclude here as the first part, and will like to switch over to the next one. Give me a minute. Something is wrong. Share. Second one. Off करिए. Okay. Yeah. Mail से लीजिए. Mail. Something wrong has happened. लोग निकल गए क्या? Next one, hyaluronic acid.
Sir, what is the problem?
Yes, I had second part. I am trying to upload the second part. Somehow it is kept. आपने लोड किया ना, सेंट में देखो ना, सेंट।
अरे नाही ना मग. कोण निघालो.
Yes. Is my screen visible?
Right.
Right. No, the screen is again not visible. Stop. Save. Yes. Is my screen visible now?
Sir. Yes, sir.
Okay. Okay. So, friends, I was talking about various intra-articular injections, which in phase 2 and phase 3 trials seem to be very effective, but because of undesirable side effects related to cardiac events, they did not get that final approval. So, what is the most common one used these days? Is hyaluronic Am I audible? Am I audible?
Yes, sir.
Yes, sir. Yes, sir.
Okay. Okay. So all of us are aware that it is the synovial fluid which lubricates the joint and has chemical component, and there are various glycosaminoglycans, and one of them is hyaluronic acid, which is responsible for viscosity, and there is lubricin, which is responsible for cartilage. No, there is collagenase, which is responsible for cartilage breakdown, and proteinases, which is responsible for protein breakdown. There are cellular constituents, and they consist of leukocyte, lymphocyte, and synovial cells. So, I am not able to change.
Sir, make it full screen first.
It is not full screen. Oh,
No,
I
no.
see it in full screen.
And you have opened in, I think, WPS file. I don't
Okay.
know whether you have to open it in PowerPoint only. That is the reason it's not opening. It's not changing, I
हाँ,
think.
नहीं आया नहीं. My screen is not visible in full screen ना. Full
No.
screen एक बार end show करिए. Right. फिर यहाँ पे full screen करिए. क्या है रो?
तो हम करंट स्लाइड करके देखिए सर.
हाँ वही किया है. Still
सर
not
ये
visible.
आपने WPS ऑफिस से खोल रखा है. इसको आप पावर
ओहो.
पॉइंट में खोलिए.
अच्छा.
इसको बंद करके फिर से खोलिए. देखिए
बंद
ओपन
करिए.
विद करके पावर पॉइंट में खोलिए.
Right.
इसलिए वो नहीं हो रहा है. जैसे देखिए वो अपग्रेड मांग रहा है आपका.
हाँ हाँ हाँ. WPS को बंद करके. Yes, you are right. मेल में जाइए. मेल में.
In the meantime, sir gets
Yes,
his
please.
system right.
All right.
I'll just like to add some points.
Please.
Anybody who has any question, please raise a hand so that I can direct the question, direct the mic towards him, and then he can unmute and then ask the question. Sir, are we ready?
Yes, yes, I'm there.
So you will face the same problem.
But is the screen even visible in a small
So
size?
it is visible, but you will not be able to change it. Sir, it is asking for an update.
Yes, yes.
Huh. So what you have to do is you have to save it on your desktop and then open. It will show you open with. So in that you do PowerPoint, not WPS. Then you will be able to do it, sir.
Mhm.
Or if you can mail it to me, I'll do it.
Okay. Is still same?
Yes, sir. You have to close this and you have to
Close it.
again open it with PowerPoint. You have to save it somewhere on your desktop and then open it.
Stop share करिए. Stop.
Also,
share.
in the same, like there is down, you will say, see the number of slide is single. तो नीचे में जाके उसको आपको क्लिक करना होगा तो वो फुल स्क्रीन ले लेगा पता चलेगा
As Anish sir said, if you have any questions, you can put up. I think Anish sir will answer.
Oh,
Yes, in the meantime, I think let's, till Sir gets his PowerPoint ready. Is there any question anybody has? Can you please,
There's a message. There's no question. I think we are waiting for.
So in the chat, I've got. No, I don't have any question in the chat.
No, there are no questions at present.
All right. Yeah. So anybody has got it, just can raise the hand or any question they have. In the meantime, we can start some discussion.
सब कुछ बंद कर दो. Mail खोल लो.
So okay, if nobody is right now interested in got any points to question, I have a few points from the talk sir has given till now, and the question arises that he has talked about disease modifying intra-articular therapies, but why they have not been approved till date. One is, as far as the data shows, that they don't work in advanced or severe osteoarthritis. They work in early osteoarthritis, and that is why the studies are not really going through. You have to have a base cartilage level to have them work. So we are still looking at something that we'll have to use it much earlier than a presentation kind of an osteoarthritis. So again, any views on that we can discuss. Second thing is that he talked about inflammatory theory. That's all right, but the recent article by Dr. Wesh and Dr. Handa and his colleagues from Apollo about talking about the various phenotypes of osteoarthritis. There's a good insight in looking at osteoarthritis from all different angles and understanding that it is not just a single entity. You could be having a higher inflammatory load, a metabolic load, or a degenerative load, whatever, different types of osteoarthritis may be there, and they can be tackled separately. So yes, that's a very good study to look at, how to look at the various types of phenotypes of osteoarthritis. A word about
So,
stem cell therapy. Yes, anything? Sorry.
so there are few
Any question?
questions. There are questions, sir. There is a question by Dr. Nidhi. She's asked, sir,
Okay.
based on your experience in.
I'll go to
Yes.
that. Wait a second.
Is it visible now?
Yes, you can continue with this, sir. Yes.
Yes. Okay, Dr. Jha, please continue.
Okay. Full size.
So let it be like this. It's okay. You can continue.
Okay. Full size.
Yes, sir. Continue. So just close this line thing and then this you can continue.
हाँ,
साइड में जहाँ पे स्लाइड्स दिख रही है ना आप
हाँ,
उसी में से
आगे
कर लो
Right. Okay. I am audible?
Yes,
Yes,
sir.
sir. Please carry
Okay.
on.
So what I was trying to say, that synovial fluid one component is glycosaminoglycans, and one of the glycosaminoglycans is hyaluronic acid. Now, we talk about visco-supplementation, and there are, all of us are concerned, various generation. The first and second generation were animal source, first generation multiple sorts, and the second generation only single sort was required. But being from the animal source, they were not biocompatible. Whereas the third generation and fourth generation were biocompatible because they were developed into the Petri dish and it was not an animal source. So the fifth generation is now here, and most of us must be aware about this fifth generation hyaluronic acid, what it is. And this is not visco-supplementation, this is visco-adaptiveness character of this fifth generation. This is a Swiss technology, and they have a patented formula where the sodium hyaluronic acid is used 20 milligram per ml. They are biofermentive in origin, that I said they are developed into Petri dish. Sorbitol is another combination which is 4%, and the total volume is 2 ml. Now there are 4 important points as far as this hyaluronic acid is concerned. Number 1, this is a patented visco-adaptive property. It breaks the oxidative loops, improves the cartilage elasticity, and it has unique visco-antalgic effect. Let's look into the patented visco-adaptive property. What we mean to say, there could be either a high viscosity with low elasticity, which can change into low viscosity and high elasticity. This is known as visco-adaptive, depending on what movements are taking place in the knee joint. So you can see on the left side that if there is less load, the viscosity is more and elasticity is less. Whereas if you are giving more mechanical stress, like you are walking at a faster speed or maybe running, the viscosity is less and the elasticity is more, and they can be represented here above and below. So they are effective and they work as shock absorber, and it limits the friction inside the joint. Now, so we have to compare between visco-supplementation and visco-adaptiveness. First to fourth generation hyaluronic acid are visco-supplement, and this one is a fifth generation is a visco-adaptive. Now let's go to the second point. What normally happens in osteoarthritic process? Osteoarthritis causes mechanical cartilage destruction. So there is inflammation and there are free radicals like reactive oxygen species radicals and nitric oxide radicals, and they decrease hyaluronic acid molecular weight, and they destroy the chondrocytes, leading to pain. So this is normal osteoarthritis process. When we break the oxidative loop, what happens? All the pathways with the effect of fifth generation higher dose hydroxyapatite and sorbitol, what they do is that they oxidative stress uh, normally on oxidative stress produces an imbalance between the ability of the body to counteract or detoxify their harmful effect through neutralization by the antioxidants, and antioxidants are molecules present in cells that prevent the reaction of free radical. Currently,
Sir, excuse me, sir, I don't think your slides are moving.
oh no, is that right?
At my end, it is not moving.
Not moving? Again,
Sir.
some problem?
Sir, do it manually. It's okay.
Okay. My slides are not visible,
No,
not
if they are
moving.
visible, but we can just see the first slide about on hyaluronic acid. That's it.
Oh
After
my
that, it has
God.
not gone then.
Why it should be? देखो भाई.
So can you manually,
हाँ,
just
yes,
do
yes,
this,
manually
go up
करा
and down.
दीजिए sir. हाँ,
हाँ,
manually
manually ये
करा
कर
दीजिए.
लीजिए, that will be fine.
Yes, okay. This is visible?
Yes, or we can understand oxidative stress, that's what is showing.
Right. ये नहीं जा रहा. Slide show. Okay. Now you can see it?
So what you need to do is press on the slide that you want to show. It will come on the larger screen.
छोटा कर लेते हैं. ठीक. Hey. Right. Could we see this one? First generation, second
Yes, we've
generation?
seen this now. Yes.
Okay. So, viscose supplementation, there are currently 4 generations.
Sir, continue from where you left off. We have, because it will be repeating.
Oh, okay. So, the 5th generation is viscoadaptive. The 5th generation is a Swiss technology in which sorbitol also has been added. The sodium hyaluronic acid is 2 ml and hydroxyapatite 2%, hyaluronic acid 2% is 40 milligram. Sorbitol 4% is 80 milligram. The advantage is it can be stored at room temperature and does not require any refrigeration. The next point, normally it has high viscosity and low elasticity if there is low stress to the knee. If the stress is high, it could be low viscosity and high elasticity. They are viscoadaptive, and as I had earlier said, less load, viscosity is more and elasticity is less. More load, viscosity is less and elasticity is more. Reaction of the synovial fluid to the movement can be seen both ways, and effect on the cartilage is that there is a limitation of friction and there is shock absorption. Now, visco supplement versus viscoadaptive. First to fourth I have already said they are visco supplementation, and the 5th one is viscoadaptive. Now, the next one. Normally what happens in osteoarthritis process, osteoarthritis causes mechanical cartilage destruction. There is simultaneous inflammation and there are oxygen-free radicals. They ultimately lead to decrease of hyaluronic acid molecular weight, and they destroy the chondrocytes and synoviocytes, leading into pain. Now, what happens when fifth generation higher dose of hyaluronic acid and sorbitol is given? All these pathways, they are blocked, and hence the pain also does get blocked, and the oxygen free radicals are not there. Now, let us understand the oxidative stress. Oxidative stress is an imbalance between ROS and the ability of the body to counteract or detoxify their harmful effects through neutralization by antioxidant. So antioxidants are molecules present in the cells that prevent the reactions of free radicals. Currently, hyaluronic acid is available in market dose, and they have antioxidant property. So fifth generation hyaluronic acid restores chondrocyte homeostasis, and the hyaluronic acid is present in gel form, which is more 21% viscous and 54% more elastic than young synovial fluid. Now, the third one, improved cartilage. So what it does is, when again higher dose is given, it blocks the other pathways also, including the pathway responsible for inflammation. And so there is no pain, and the inflammation gets tackled. So viscoenterology concept is the answer to treat osteoarthritis patients. There is faster pain relief as early as 1 week after the first injection. 70% of the patients are responders. Intense pain relief does get into. Patients presents a strong pain relief immediately after the first injection, of patients refer no or only slight pain after 2 weeks. Pain relief is controlled within 65% of the patient is still reporting improvement in joint function after 6 months. Co-medication is reduced. So, the unique synergistic action of hyaluronic acid and sorbitol in this patented formulation is there. Hyaluronic acid is 2%, sorbitol is 4%, and they synergistically deliver a high performance gel formation. So finally, we can sum up that it relieves, the fifth generation relieves pain in osteoarthritis and works at all the levels of cartilage, subchondral bone, periosteum, osteophyte, synovial fluid, and synovium. There are few clinical studies and pain reduction assessment in 1,147 patients using combined sodium hyaluronate and sorbitol viscosupplementation, which has concluded that viscosupplementation using the combination of sodium hyaluronate and sorbitol has been observed to significantly and safely reduce both joint pain and functional impairment for patients with osteoarthritis at all KL grades on a period of 24 weeks at least. A second study says addition of sorbitol to hyaluronic acid may reduce the onset of action of viscosupplementation in patient with symptomatic knee arthritis. And it concludes that the exploratory study suggests a quick and strong pain relief occurring immediately after the first injection of antioxidant versus viscosupplementation, followed by a continuous improvement until the end of follow-up. Improvement was achieved much faster than that obtained with other viscosupplements, probably because of the presence of high concentration of sorbitol through its antioxidant activity. These data
Sir,
the
so
need
we are running short of time for
right, so
discussion. Can
need
we?
for a large scale prospective clinical trial. And finally, only this is the only Swiss brand with viscoadaptive nature, only brand with antioxidant sorbitol. There is crossover frequency, and latest fifth generation, as I have told, this is 2% strength and can be used in all osteoarthritic joints. Thank you.
Thank you, sir. And we have a few questions. I'll
Please.
start with the first one. One is from Nidesh Chandra. It talks about, he's asking us that at what stage of
Stage 2 and stage 3, rather late stage 2 and stage 3. They also can be our subjects for hyaluronic acid.
So I'll answer the next question, which is there by Abhinav Singh, which is about oral or IV bisphosphonate, which one is better? So I think it's all about compliance and one injection working for a long period. If you can get compliance with oral, then probably they work the same. Am I right, sir?
You are perfectly right. And it should always be intravenous whenever the patient comes to you. And I have invariably found the next time the same patient comes with another patient that I was given this one and this was very effective. But at the same time, you have to be very cautious in explaining them that following this intravenous zoledronic acid, you might get fever, nausea,
Fever.
and body ache. And for that reason, you must prescribe the patient paracetamol injections or maybe even tablets.
There is also a possibility of acute renal shutdown. So very high
Yes,
hydration is
yes,
also advised.
right.
Okay, so next question is I'll skip the first one, go to the next one because it's reverse question. So which brand of fifth generation drug are you talking about, sir?
This is a Zydus
Okay,
Ilasto S.
one. Okay,
Ilasto.
Electro-S. So the question about what is the protocol to use viscoadaptive injections is there by Dr. Nidesh. Would you like to? I think you already told us the protocol, most of it.
Generally, whenever you are giving any intra-articular injection, you have to look into, is the skin healthy in that region? Other parameters are good enough, so the patient does not have other diseases, which can be a contradictory thing. And many a times, even hyaluronic acid, you like to give because they take some time to act. You can combine them with hydrocortisone or methylprednisolone, and this combination has been found to be more effective.
So I'll
But for this fifth generation.
Yeah, so about this very drug which you were talking about, I have certain points to add. The studies that you showed us describe the use of this drug in a serial injection. It is not a single shot injection as per the studies. It's given as a serial injection, one and one after 1 week. The visto-adaptive part which you were talking about is the rheological property of the drug. The
Right.
effect on pain management or the reduction in pain vis-a-vis the other viscosupplements, that is the fifth generation property, is because of sorbitol. The sorbitol is an basically it's a pain relieving treatment, and it works for around the first 30 days of the injection. So the advantage of using this injection is that you get pain relief till hyaluronic acid starts its work, because it takes around 2 to 3 weeks or maybe more for hyaluronic to be effective. So what normally people are doing, they do an intra-articular glucocorticoid before they do viscosupplementation. In
Yes.
this case, it is not required, and you get that pain relief which you get from glucocorticoid. The advantage again is there that in diabetic patients where glucocorticoid injections are contraindicated, you get a better, better option on your armamentarium. But the problem here lies is the cost of therapy, because it is two injections, not one injection that you have to use to get adequate result as far as that is concerned. And second problem that lies is the viscoelastic property per se of the drug they have used to combine with the sorbitol. They have not used a cost-linked variety of viscosupplement to combine with the sorbitol, and they have put it at 20 mg per ml. So if you look at the comparative studies in long-term outcomes, they are not really that great. But yes, in acute setting, maybe we can go for this drug. Just a word about, because I did a lot of research on this product when it came into the market. So I just had some inputs to help you out with that. Anyway, any other questions we have?
Can I add one thing? That
Yes.
now they have a 6 ml formulation, and this has to be given only one shot.
Yes. So that is what it was. The initial injection was 2 ml, which they got it. They the studies which they had done in Europe was with 2 ml two shots and 6 ml single shot. They
Right.
did not get the 6 ml direct to India at all. And that
Right.
was the bone of contention, that we need at least two injections to give when we are using 2 ml two shots. So some studies were even using three injections. So serial injection again is a big problem. As we all understand, patient compliance is poor. And the reason for giving serial injection was longer retention time in the joint, because after 1 week there's a degenerative process. So that is why the very high molecular weight viscosupplementations came into the market that have their own long retention time in the joint.
I have a question, sir. You talked about a local anesthetic, the newer ones.
Right.
So are they available in India? And
Prelokin now is available.
okay.
Yeah.
So do you inject it in the joint or just
Yes, we inject into the joint. Uh, Reason being that the patient for some time does not get that pain. You can do it even without it, but invariably we do it.
so we have
Ev-
been using lignocaine. We just mix a bit of lignocaine and inject in the joint. So is it freely available? So you can just replace lignocaine with the newer one?
I will. It is not available in Patna, but I have come to
Okay.
know that now it is available in India. Uh,
Okay, so yes, it is available in India. That is one point. Second point is the content of lignocaine being methyl paraben, that is a preservative in lignocaine. That is a highly
Cartilage.
cartilage degenerative product. Second thing is, you should not combine lignocaine with visco supplements, but yes, you can combine them with the steroids.
So we combine with only with steroid, not with this with
Yes,
the
perfect.
visco
Perfect.
supplementation.
Yes, perfect. Perfect. Any other questions?
No
Right. So
question. So
I think we are pretty late, and it's already 9:33, and people are waiting for dinner. So let me, if it's okay, we can ask those questions personally also, and we all have our contacts. So let me sum it up. Uh, a very illustrated, very nice talk by Dr. Jha. He has encompassed all the various, intra-articular therapies which were tried and tested and did not work, or were not allowed to work, or were not allowed to be used. So he has given us the whole, uh, what I say, the armamentarium of intra-articular therapies and what may come in the future. And yes, we should be looking at not only joint preservation, we should also be looking at joint reversing the joint damages if possible, and that is something that the future holds for us. There are certain studies of following viscosub. In fact, one of them is my study only, which I published in APLAR, which is following viscosupplementation by after intraarticular glucocorticoid to prevent the long-term glucocorticoid damage that can happen. But then there is a lot going on, and I think intra-articular therapies are still coming of age, and they have been, now the focus has shifted onto it. And I'd like to thank Dr. Jha and all the attendees for being here and participating in the meeting. Thank you so much. And with this, we can say good night to.
Thank you very much.
Thank you.
Good night, sir. Thank you, sir.
Good night.
Could not avoid the hiccups that I had. Right.
Good night. Great
That's
talk,
okay,
sir.
sir. Good night. Good night.